Dr. Babji Shyamkumar Garu, Senior Consultant Neurosurgeon from from SMC Vijayawada. Dr. Amit T, Senior Neurosurgeon Consultant from Vijaya Super Speciality Hospitals, Vijayawada. Dr. Venkatramana Murthy Garu, Senior Consultant Neurosurgeon, Apollo Speciality Hospital, Nellore. Welcome you, sir. Dr. Shekhar Sheshadri Garu, Senior Consultant Neurosurgeon, Kanmuri Hospitals, Guntur. Dr. Hanuma Srinivas Reddy Garu, Senior Consultant Neurosurgeon from Brinda Neurocenter, Guntur.
Okay, now I invite Dr. Prudhvi M, Senior Consultant Neurosurgeon, Aster Ramesh Hospitals, Vijayawada. And he completed his neurosurgery in NIMHANS, Bangalore, and performed many complex neurovascular surgical procedures. I welcome onto the stage to take the topic, Surgical Strike Against Stroke, Timely Decisions and Life-Saving Actions by Dr. Prudhvi M. Thank you.
Good morning, everyone. As my previous sections talked about the medical management and thrombectomy, I am going to brief about the surgical options in stroke. As per the Indian Journal of Medical Research, globally there are 15 million people suffer from stroke every year, and 6.5 million die of the stroke, and 5 million are left disabled. In India, it is about 1.5 million annually. And one stroke, and every 40 seconds, one stroke case is come to the hospital, and one death occurs in every 4 minutes. And 30% of the stroke patients in India are below 45 years. Understanding our target is very important in the stroke. Our target is, we all know that our target is the penumbra around the ischemic area and hemorrhagic region. So all our measures like medical management or whatever are to save the penumbra. BFAST is the acronym given to identify the signs and symptoms of the stroke. That is the loss of balance and sudden loss of vision or double vision or blurring of vision, and facial drooping, arm weakness and slurring of the speech. Then it is time to go to the hospital. This is the Los Angeles Motor Score and race score are two scores for stroke. If the LAMS is more than 4, then it is large vessel and occlusion, and race score is greater than 4 or 5, greater than 5. Then it is considered as a large occlusion, large vessel occlusion. A CPS scale, if it is, if anything is abnormal in CPS scale, then the stroke probability would be around 72%. Our battle plan. Now, these are about the thrombolytics and thrombectomy. So I am skipping these slides, going to the surgical management as the time is limited. Surgical options for the ICH are the decompressive craniectomy with bleed evacuation, and mini craniotomy and evacuation of the ICH, and minimal invasive surgery, that is the endoscopic evacuation and stereostatic aspiration, and minimally invasive surgery with RTA. What is the criteria for the evacuation? Here in cerebellar hematoma, if the volume is greater, more than 3 centimeters, or diameter, or if it is more than 15 ml, or any neurological deterioration or brainstem compression, then we will go for surgical evacuation. Or if any hydrocephalus is present due to the obstruction of the fourth ventricle, then we will go for evacuation with or without EVD. Then while coming to the lower hematoma, if the hematoma is more than 30 ml within 1 centimeter from the cortical surface, then we can evacuate the ICH. Then if there is any progressive neurological deterioration or significant mass effect and young individuals with good baseline, we can go for the evacuation. Usually basal ganglia and thalamic hematomas are managed conservatively, but if there is any mass effect, then consider for minimal invasive. If there is any IVH, then go for EVD and with or without fibrinolysis. Decompressive craniectomy. Stitch 1, as we all know, the decompressive craniectomy is we are using for the long time. But Stitch 1 and Stitch 2 trials, which they said that there is no overall benefit from the early surgery versus the initial conservative management. But there is but secondary analysis say that there is a favorable outcome and mortality, decrease in mortality in early surgery group compared to the medical management, but they are not statistically significant. Minimal invasive surgery endoscopic evacuation. This is the young patient which came to me with ICH. Initially we have tried for the medical management, but the patient got deteriorated. Then we have done the minimal invasive surgery where we have done the small craniotomy here, and then we have went with the endoscope inside into the hematoma with endoscopic endoport assisted. Then and the hematoma was evacuated. This is the post-op CT head after the evacuation. Minimally invasive surgery with tissue plasminogen. This is the one of the lobar hematoma where we have introduced the small catheter into the middle two-third of the hematoma, and we have given the altiplase 1 gram with 1 milligram in 1 ml NS, and then 3 to 4 ml was flushed into it. And then we have closed it for an hour, and then opened it, and we have left it for the gravity. And this was repeated for another 4 doses, but we can give it for still 9 doses. But this is the post CT head showing there is a reduction in the clot, and after that we have taken out the catheter. This is the MISTI trial on minimal invasive surgery with thrombolysis. It said that there is no improvement in the functional outcome, but secondary analysis showed that there is a low mortality rate compared to the standard medical care, and there is no net increase in the patients with the severe disability. IVH with the hydrocephalus. In this, we can introduce the catheter into the ventricles, and then we can give the altiplase same as we have discussed before. That is 1 mg in 1 ml saline, and then 4 to 5 ml of flush. Then close it for an hour, and then open it and leave it to the gravity. Then the clot will get lysed and then drained through the gravity. And you can see the post CT head after 24 hours showing there is a clot lysis, and then post catheter day 4 there is complete almost 90% there is a clot lysis, which was a good thing. And there was one trial called Clear 3. In this they said that the primary it showed that the primary IVH has the better outcomes than the secondary IVH, and then when compared to the medical usual conservative methods, mortality rate is a little bit the functional outcomes are improved. And then this another trial called Enrich showed that the surgical group has the low mortality rate at 30 days compared to the medical management group. Thank you, sir.
Okay, very good.